Hi, friends. We are going to talk about care and management of the critical patient with infectious immune diseases. Your outline has nursing assessment, which we'll cover here. It has severe acute respiratory syndrome and then SARS-CoV, Middle Eastern respiratory syndrome, MERS-CoV, and then coronavirus disease, and then SARS-CoV. I'm going to cover all of that in class because there's not a lot of information in your book about it, and there's not a lot of information on ATI about it. So um, we're going to do some work together in class with that. But I am going to cover HIV and AIDS. Okay. So, like I said, we're going to cover care and management of critical patient with infectious immune diseases. We have Bruner and Siddharth, chapter 31 and 32. We have ATI chapter 85 and 87, and then there's going to be some Lippincott resources that I'm going to upload, as well as some resources that we um, look at in class. So let's talk about an immune system overview. So the definition here is going to be specific protective response against foreign agents, involves genetic and cellular reactions. So we're going to have a defense mechanism based on a rapid targeted response. There's going to be an immune memory with long term protection, a tolerance, self versus non self distinction, and a surveillance, so monitoring for invaders like cancer. When we have immune dysfunction, we end up with immune system diseases. The causes could be genetic or acquired, and the disorders would be autoimmune diseases, which are higher in females, cancers, and infections. So, for our immune system assessment, and I apologize, this is so small, we want to know the patient's immunization status, so their vaccines, and are they adhering to the adult schedules? We want to know their infection history, so past or present infections, any exposure to TB, recent travel, bloodborne pathogens, and then any STIs, gonorrhea, syphilis, HPV, HSV, things like that. Then we're going to ask about allergies. So, do we have any allergens to pollens, food, medications, latex, vaccines, any documentation about alerts in our EHR? Oh. And then, do they have any disorders, diseases like autoimmune or neoplastic, chronic illnesses? Do they have any surgeries or procedures? Do they take any medications such as immunosuppressants or any herbal or over the counter? And then have they had any blood transfusions? It was a risk to HIV pre 1985, but post 1985, we're really good at screening that out. So our physical exam for the immune assessment is going to be skin and mucous membranes. We want to look for any lesions, dermatitis, purpura, urticaria, discharge. We want to look at those lymph nodes. We want to palpate cervical, axillary, inguinal nodes. We want to note the size and tenderness. Are our joints warped? Is there swelling? Is there limited mobility? Um, How's our respiratory system? Do we know any cough or dyspnea? How's our cardiovascular? How's our perfusion? How's our genitourinary? Are there any UTI signs? Is there any GI signs? Any neurosensory? And then our vital signs would show any fever, chills, or night sweats. So, key factors affecting immunity are going to be gender. So, estrogen enhances immunity, which means that we have an autoimmune risk in females, and then autoimmune disease are the leading cause of death in reproductive age women. And then aging, so we have a reduced vaccine efficacy. Nutrition, so if we have deficiencies in protein, zinc, or iron, we have an increased infection risk. What's our lifestyle like? Do we have any smoking or alcohol, drug use, pollution that has a negative effect on our immunity? Do we have overexertion like rigorous exercise or stress, which can lead to stress-induced immunosuppression? And then psychoneuroimmunologic factors like bidirectional brain immune axis, stress impact, biobehavioral strategies. And our nursing focus is going to be on assessing psychological status and encouraging stress management techniques. We're going to look at labs like a CBC to look at those white counts, immunoglobulin levels, HIV, hepatitis serology. We could do a TB skin test, allergy testing. We could do a bone marrow biopsy for that hematopoietic function. Autoimmune markers are going to be your ANA, your sed rate, your CRP. We can do some imaging and chest x-ray will show TB. CT MRI for lymph node or organ involvement. Nursing implications, we're going to advocate for vaccines. We want to promote age-appropriate schedules. Know what that age-appropriate schedule is. You can find it easily online. Your infection monitoring, so post-stroke pneumonia, post-op sepsis, chronic wound care. You want to screen for any immunosuppressants and educate on herbal interactions. And we want to make sure that we document any allergies, any STIs, exposures, or transfusion history if it's not already noted. And then offer that psychosocial support. So anxiety management, education, holistic care. Nursing considerations for immune issues. Again, that vaccine schedule. There's a table in your book, 3-3 in this chapter. So know what that is. TB testing, so we can do a PPD interpretation. Those immune labs are ANA, sed rate, and CRP. Tumor antigens blocking immune response. There could be some chemo side effects like neutropenia. Psychoneuroimmunology, stress impact. Priority interventions are going to be isolation protocols for immunocompromised patients. Now let's dive into HIV and AIDS. So our historical overview. So in 1981, AIDS was first identified. In our first decade, there was a focus on managing opportunistic infections via prophylaxis. In the second decade, we were introduced to HAART, highly active antiretroviral therapy, which transformed HIV into a chronic condition. And then in the third decade, we had an emphasis on prevention, adherence to ART, so that antiretroviral therapy, and a combination therapies targeting viral life cycle stages in vaccine research. In 1984, we developed the HIV antibody test, the ELISA, which enabled early diagnosis. So the CDC case definitions are stage 0, which is early HIV infection, so lab confirmed within 6 months. Stages 1 through 3 are based on CD4 counts. Stage 1 is greater than or equal to 500. Stage 2 is 200 to 499, and stage 3 is less than 200. Stage unknown is if we don't have any CD4 data. 1 million individuals in the United States are living with HIV. 500,000 are with AIDS. Transmission is 70% male to male sexual contact and 24% heterosexual contact. Our demographics is going to be the highest rates among Black and African Americans, ages 25 to 29. And the southern US has the highest regional prevalence. As far as our global impact, and this data is a little old, it was last updated in 2019, according to your book, but I'm sure you could find newer data. We have 37.9 million people living with HIV/AIDS globally, 1.7 million new infections per year. In Africa, we have 25.7 million people living with HIV and AIDS. 2/3 of global new infections, and new infections decreased by 37%, and HIV deaths have decreased by 45%. So we're making strides in treating this. So HIV is transmitted through body fluids, blood, semen, vaginal secretions, and breast milk. High risk exposures are going to be inflammation, breaks in the skin, mucosa, perinatal exposure. So labor and delivery is most common. And blood safety. We've done rigorous donor screening and testing, which minimizes transfusion risk. For healthcares, you want to use standard precautions on every patient. And if you were to be exposed, you want to get to post-exposure prophylaxis, and you want to initiate that within 72 hours of potential HIV exposure. As far as the vaccination, so there's ongoing research for an effective HIV vaccine. Challenges include HIV's rapid mutation rate and genetic diversity. Major group M and outlier subtype B dominates in Western countries. Again, we talked about those stages of HIV infection. So we have acute HIV infection. So you've gotten a test within 6 months. Your symptoms are going to be 40 to 80% experience flu-like illness, which is what sends you to the doctor. Testing is going to be a negative antibody test, but detectable RNA via PCR. In stage 1, you might be asymptomatic. You can be asymptomatic with 8 to 10 years without ART. And then stage 2, you're going to be symptomatic because your CD4 count is down. So symptoms can include recurrent infections. And then stage 3, that CD4 count less than 200 is where we're going to move into AIDS, and it's risk for severe opportunistic infections. You want to support these patients. So pathophysiology, we have a retrovirus. So we have HIV-1 and HIV-2. This contains viral RNA and critical enzymes. So reverse transcriptase, integrase, and protease. The envelope has got glycoproteins that facilitate CD4 cell entry. The target cells are going to be those CD4 receptors. They're present on T lymphocytes, monocytes, dendritic cells, and brain microglia. And the life cycle, so the binding entry, the GP120 binds with the CD4, and GP41 mediates fusion. Viral RNA moves to DNA. Viral DNA integrates into host genome as provirus. Activated T cells produce viral RNA proteins, and new virins released, destroying host cells. The key mutations here is HIV-1 mutates rapidly, evading immune detection and complicating treatment and vaccine design. So our assessment and diagnostic findings, so that clinical presentation will often tell us what stage we're in. A diagnostic testing is going to be an HIV antibody test, viral load testing, and then we have treatment milestones. So HAART and ART will reduce the viral load and preserves the CD4 counts. And then we could do prophylaxis treatment just for patients who might have high risk for developing HIV, but can't change those risk factors. There are also gerontologic considerations. So 35% of adults get diagnosed at late stages. Common conditions include diabetes, cardiovascular disease, osteoporosis, and depression. And the challenges would be polypharmacy, so these drug interactions with ART, and then loneliness. This is likely linked to substance abuse, functional impairment, and increased mortality. Diagnostic testing, again, is that HIV antibody testing, viral load testing, and CD4 cell count. And our nursing priorities are going to be emphasis on adherence to ART, safe sex practices, and the U equals U principle. Undetectable equals untransmittable. Screening, we want to advocate for routine testing in high-risk groups, including older adults. We want to monitor for signs such as thrush, weight loss, and fever. Initiate prophylaxis as needed. So that would be prophylaxis like antibiotics as needed. And then address stigma, mental health issues, and loneliness, especially in those elderly. So what is the role of the nurse in preventing HIV infection, it's really education on risk reduction with a focus on younger adults. We want to address cultural, religious barriers and discordant couples and advocate for patient autonomy. We could have pre-exposure prophylaxis. So this is going to be daily oral tenofovir. Um, this is going to be patients who have not been exposed, but again, have the lifestyle where they may have an exposure. So we would treat them with our regimen. So our tenofovir and the and I can't say that, so I'm so sorry. And the efficacy is going to be reduce sexual HIV acquisition risk by up to 92% with consistent use. And we want to monitor these patients every 3 months and continue condom use to prevent other STIs because the pre-exposure prophylaxis will not stop other STIs. And then preventative education strategies are going to be promote safe sex, condom use, and harm reduction. HIV testing, encourage behavior change and routine screening for ages 13 to 64. And early ART initiation improves outcomes and reduces transmission. And while we're talking about education for safe sex practices, we should discuss the barrier methods for our patients. So, male condoms are effective, non latex do not protect against HIV. So, it's important to share that with your patients. And then for female condoms, polyurethane barrier, it's effective against HIV and genital secretions. So, female to female would help with that, or female to male, because genital secretions are also a body fluid. And then there's dental dams for oral, vaginal, and anal contact. I spoke about harm reduction. Harm reduction is in substance use. So we have syringe service programs where programs will provide sterile needles, safe disposal, and links to healthcare. And the impact will helps reduce bloodborne infections without increasing drug use. And then we would give our patients reproductive education. So discordant couples can use ART for HIV positive partners, which will reduce the transmission risk during conception. For pregnancy, ART during pregnancy reduces perinatal transmission to less than 1%. And then for breastfeeding, we want to avoid in resource rich settings, exclusive breastfeeding and maternal ART advised in low resource areas. LGBTQ, I should have added more letters. It's LGBTQIA plus now, I believe. Considerations. So these are high risk groups. Young gay men account for the majority of HIV cases. Cultural competence, address the stigma and social determinants of health. Social determinants of health are so important with fixing healthcare. So please pay attention to those. And then tailored interventions, culturally sensitive education on PrEP, condoms, and testing. There's also some emotional and ethical concerns in nursing. So this can be really challenging for nurses. Nurses may want to deal with these patients because they're fear of being infected. There might be some moral distress with caring for patients with stigmatized behaviors, and some confidentiality dilemmas, balancing patient privacy and partner notification. The ANA Code of Ethics provides a little bit of guidance. So you want to provide care with compassion and respect for inherent dignity, and you want to protect patient privacy unless legally mandated to disclose. And then your strategies for ethical practice is values clarification. So you want to reflect on your own personal bias. And if you're not able to care for this patient, then you want to be real with yourself on that. And you want to let your superior know. And then you also might want to consult ethics committees and specialists. And then you can educate on disclosure to partners if a patient does not want to disclose to their partner, but you can't tell their partner. And then you want to support healthcare teams. So, staff education, regular updates on HIV transmission and treatment. There's support groups, address grief and moral distress. And then you want to do debriefing sessions right after. That is it. We will go over a lot of this in class on Wednesday, and I'm looking forward to it. See you later.